Hi guys. My name is Dee Dee, and since I qualified, I've just loved all things anaesthesia, so I'm probably equally as passionate as Emma was about cardio down there. And we kind of have a few points on from leading to Bliss, anaesthesia of the Haemoabdomen. This is partly, obviously, Ralph's journey through anaesthesia, but it's also a little bit of a showboat of how amazing anaesthesia is. And if anyone's exceptionally interested in it or would like to become interested in it, come and speak to me afterwards. We're just an amazing department. So, so just to show the team, it's an absolute stringboat combination of hard work and fun, of course, making sure that the patient is always at the pinnacle of everything that we do. And I think we can definitely take pride on how well we look after each other as a team as well. Just to show kind of, this is our head of anaesthesia here. We do a lot of CPD, a lot of seminars. These are kind of how we set up our cases with clipboards. We'll go through the patients the night before. Once we have an opportunity to do that, we prepare all of our trays. We take part as nurses, so here I am with Andrew, our anaesthetist, and here's Kim with Robyn, our anaesthetist. So we take part in the local blocks that we can do under Schedule 3. This is Bliss, one of our anaesthesia theatre nurses, scrubbed in with our surgeon or orthosurgeon. We do huddles here, so this is us. We have a respite every 2 weeks to just spend time together as a team and to listen to each department. And the Ralph very kindly offers kind of food and drinks for us on that morning. So for 30 minutes we have a protected time. And this is Ralph here, kind of having lots of love with our internal medicine VTS, and Tonry, his carer. He's our dentistry nurse. So just to say what the anaesthesia department does as a whole, but anaesthesia theatre is very much intertwined here. You can just kind of have a look around, but we have a huge role to play in every patient really that comes into the Ralph, and a lot of them do come through our department. We have a massive kind of range of things that we do throughout the day, and as nurses we are absolutely involved in the majority of this. I would say the primary kind of part we aren't maybe is just referral support, because the anaesthetist will provide support to referring vets in anaesthesia. And this is how we kind of present our day, and I've come in today and I see that I'm on Ralph Ralferson. So he's a golden retriever having a GA, CT thorax plus surgery for suspected splenectomy. I'm on the case, and there's just a few notes of him being in Haemoabdomen, blood type positive. He's had a transfusion, packed red blood cells, and differential diagnosis that he's got a bleeding splenic mass. So our patient. So Ralph, he's an 8-year, at this stage you know him, 8-year male neuter golden retriever, 30 kilos, and he presented to ICU with lethargy, weakness, and peritoneal effusion. Significant history is that he's got diabetes mellitus and a grade 2 out of 6 systolic heart murmur that was not investigated. And now that we know from cardio that he's got MMVDB1. That's essential really for us to know, because that either takes a lot of our drugs off the kind of board for what we can use for pre-medication, inductions, maintenance of the anaesthesia, even into the recovery period. So in this is our kind of best case scenario. All our medications are still on the board for an MMVDB1, which is great. His planned procedure is a GA CT abdomen. Surgery is indicated. His parameters are as follows for us. This is how I would kind of investigate a patient when I am given him at the beginning of the day. So he has parameters and we have our blood results. And we present this on our anaesthetic sheet as such. So we have his signalement, his pre-assessment, weight, demeanour, his significant history, problems, clinical findings, and any current medications that he's on. This patient has vascular access, 20 gauge catheter, and on discussion with Robyn, maybe this guy will be more an ASA3 and he's an emergency procedure. So this is how we present an anaesthetic case as nurses. And we go to our anaesthetist at this point and we have a discussion with them about the case. So we are very much involved from the offset. I would go to see Ralph in the ICU department. I would assess him myself. I would read his history and problem list. We are absolutely fully supported with our anaesthesia team on this. If they have capacity through troubleshooting and doing challenging cases themselves, they will support us in preparing the case. And this is how I would kind of approach Robyn at this point to discuss Ralph and how we will proceed with his anaesthesia. The anaesthesia plan that we set out, really I'm thinking about the patient, the procedure, possible problems, in this case due to procedure and comorbidities. And then as a team we will discuss how to prevent or manage these problems, and the recovery as well is very important. We tend to have an idea of how we will recover these patients. Ralph in this case will go back to the ICU department, so we'll be very much in communication with ICU throughout. And I'm just going to pass you over to Robyn.
Fab. So when Dee would come and have a chat with me about this case, I'll have probably done a bit of reading by the time we get to here. And in my head, I'm going to be thinking, right, this patient has an awful lot that's going on. How can I break this down to being as simple as possible so I don't miss anything? So the first thing I'm going to be thinking about is my patient, even if nothing else was going on at that point in time, what kind of things do I have to think about? So this patient is a golden retriever, and we are going to be thinking about this. What does that potentially mean for my anaesthetic? So golden retrievers, they're a large breed dog. So one of the first things I'm going to be thinking about is he might hypoventilate under the anaesthetic. So that's already in the back of my mind that I might need to perform IPPV, especially given the fact that I know what procedure we're going to be going on to. So I want to make sure that I'm thinking about how I'm going to prepare for that as we go forward. He's also, as I said, he's big breed. We're going to be in dorsal recumbency, so regurgitation, and we're going to have, imaging procedures as well. So we are going to be thinking that regurgitation might be a possibility with this case as well. And again, in the back of my mind, I'm going to be like, what can I get ready to make sure that if this does happen, we can minimize the risk to our patient? And then finally, it's going to be the surgical challenge. So this dog is potentially going to have quite a deep abdomen, and they're quite deep chested as well. So can I do anything that will make the surgeon's life a little bit easier? So these things are all ticking over in the back of my mind before I even anaesthetize this patient. He's also a little bit older, so there's going to be physiological changes in this patient, and there's going to be pharmacokinetic changes in this patient. So he might be more likely to become hypothermic. He might not metabolize drugs in the same way. So I'm already, again, thinking, okay, so what can I do for this patient to sort of help mitigate these risks that might lead to potentially prolonged recovery or just increased risks with the anaesthetic? So that's my patient factors, and that's without even thinking about any of his comorbidities. So then I'm going to go into my procedure-specific ones. So he's going to have an XLAP, most likely. So I am thinking, okay, pain and nociception. XLAPs are they're not a benign procedure. They do cause pain with our patients. So again, we're thinking, what analgesia can I use in this patient? How can I minimize nociception in this patient? I'm also going to be thinking about, again, he's going to be in dorsal recumbency, he's needing an XLAP, hypoventilation. So this procedure is, all these things together are starting to, you can see all the considerations are going to start accumulating together, and it all seems actually, although this patient's got a lot going on, there are fewer things that we actually think we need to worry about. And then hemorrhage. Hemorrhage is probably our biggest concern of this patient. He might be stable now. We might have a patient that is cardiovascularly doing okay. He's had his transfusion and he doesn't necessarily actively bleed now. But as soon as our surgeon starts manipulating that spleen, there is a chance for hemorrhage. And also we're going to be cutting through some large blood vessels, and depending on the way the surgeon's going to ligate those vessels, whether that is going to be through suture material or through staples, there is going to be a risk of hemorrhage from that point of view. And then condition specific. Now, I know this doesn't look the most prettiest way, but it was the only way I could think of demonstrating this. We have a patient that has got 3 major comorbidities. So we've got a splenic mass, diabetes, and mitral valve disease. I could talk a really long time about all 3 of those comorbidities. And if I had all the time in the world today, I would, but we're probably going to focus mainly on the fact that it's a bleeding splenic mass, because as much as I'd love to talk about it all, I don't have enough time. So, but in the back of my mind, I'm thinking, okay, my bleeding splenic mass, it's something in the abdomen that can be splinting my diaphragm. So again, we're going to be thinking about hypoventilation. We're going to be thinking hypotension, further hemorrhage. So what do I need? What can I have in place to try and make sure that if that does happen, I'm not increasing the risk to the patient? Diabetes, we're going to be thinking about glucose abnormalities, electrolyte abnormalities, and what do we need to do in the recovery period to make sure that he gets eating, because eating is obviously very important for our glucose management and making sure that we can continue getting our insulin. And then our mitral valve disease, main consideration we have to think of is fluid overload, because it is mitral valve disease B1. However, in this situation as well, we've obviously got bleeding splenic mass, so we're probably volume underloaded. So how much of a concern is that going to be? Well, that will depend on going forward what happens. Why is this not going? Cool. So this is, if this is what I think it is, because I can't actually see. Yes, it is. This is the arrhythmias that you can get with splenic masses. And I think everyone worries about what kind of arrhythmias we can get. And this is an accelerated, is it? Yeah. Yep, accelerated idioventricular rhythm that we've seen in one of our patients when they were here. It didn't need any management, which was great, but we just thought we'd show you that for just for the niceness of it. Yeah. Okay, so we have a huge number of things to think about. So how do I actually get that all together and make this all seem sensible, logical, and not as scary as it currently sounds? So I've basically divided all of these problems up into 6 main problems: hemorrhage, hypotension, arrhythmias, complications from the diabetes, pain and nociception, and then hypoventilation. So I now have these main problems. I am thinking, okay, what do I need to get ready from all of this? And you can see here, I've sort of listed all the kind of things I'm going to be thinking about getting out and ready before I even anaesthetize this patient. And Dee Dee is just going to have a very quick chat about some ventilation.
I'm okay. So regarding hyperventilation and intermittent positive pressure ventilation, the respiratory system is my favorite system. So if I could eradicate a few things from happening at the beginning of an anesthetic or throughout an anesthetic, that would be amazing. When we anesthetize a patient, we have given a cocktail of drugs that have just caused respiratory depression. We have, in Ralph's case, we're going to give him some methadone, dexmedetomidine, and then we're going to induce him using propofol. This patient may not want to breathe at the beginning of the anesthetic. Very common. Apnea for the first 10-15 minutes is not uncommon. How we manage the apnea is what I kind of want to streamline, so I just want this to be a bit of a take-home point. When I consider ventilating a patient, I think about his weight and I think about in this case, Ralph, I think about his tidal volume. This patient is 30 kilos and a tidal volume for a canine and feline is around 10 to 20 mil per kilo. We even go a little bit lower. We tend to work around 8 to 12 mil per kilo, and I do a smack bang in the middle, 10 mil per kilo, because it's really quick for me to calculate that. So the approximate tidal volume of Ralph's lungs is 300 mils. This is, in this case, fine because he does not have any known respiratory pathology or expected respiratory pathology. If I want to IPPV this patient using manual IPPV, I'm going to do my classic close the APL valve. I'm going to check what size bag I have. I'm going to propose I have a 2-liter bag. That's 2,000 mils, and I want to give Ralph approximately 300 mil breath. So I squeeze the bag and I look at the patient's chest, always watching the excursions of the chest, checking out bilateral movement and seeing is that a normal size breath, not a huge breath that's held for a long time. And that's how I kind of propose providing IPPV to any patient under anesthesia, particularly Ralph in our case, at the beginning of an anesthetic or throughout if you have to provide intermittent positive pressure ventilation. The second thing we consider is the peak inspiratory pressure. So this is so you don't cause any barotrauma or volutrauma. And I have a graph later showing the kind of volumes that we can change and go into when we're providing IPPV, which will kind of hone in on the tidal volume and where we're kind of aiming for when we're providing these breaths. And we don't want to reach a peak inspiratory pressure of greater than 20 centimeters of H2O. In a cat, I would aim for around 8 to 10, and in a dog with, again, no respiratory pathology in any of these hypothetical patients, I'd aim for 10, 15 centimeters of H2O. And we'll show you through pictures that there's these little pressure manometers that we can get, that we can put on anesthetic breathing systems that will help gauge us giving these breaths and the pressure that we're providing when we give the breath. So these are just two kind of take-home points, because as soon as we anesthetize a patient, we're very likely to give a breath, and we can have that knowledge on our belt and also pass that knowledge on to anyone that we're working with, even other veterinarians that may not have kind of considered the lung volumes and providing intermittent positive pressure ventilation to the patients. I'm going to pass you. Oh yeah, amazing. This is me. So I can take the clicker. Thank you. When I think of an anesthetic plan, I prepare my anesthetic sheet, my tray, medications. I consider any additional procedures that we have to do, and I set up for those. So in this patient, actually Ralph, I would perceive that we're going to potentially need suction. This patient may regurgitate, and very often they can, regurgitate at the beginning before the riskiest time is when we don't have a secure airway. So we would have regurgitation on standby. We tend to have it very close to our induction areas. We're going to place a central line, an arterial line, and the key really with anesthesia, reducing the amount of time they're under anesthesia, any patient that's high risk, is preparation, having all of these things lined up. And we have a huge role to play in that, kind of almost going, this is everything we need to do, what we need to do with Ralph in this case. A huge part of our job is communication. We have to communicate with the anaesthetist, with all the other nurses and veterinarians involved in Ralph's care. We also have to communicate, in our case, with the person who's coordinating the day. Is this the correct timing? Are we moving into CT? Is our slot available? So we have a huge, wonderful amount of kind of things to consider, which just honestly adds a huge amount of job satisfaction to what I do every day. And in this case as well, we very much hone in on checklists, because it keeps us very focused, and I find actually the time when we're more likely to make a mistake is when we're rushed, stressed, etc. So checklists definitely ground us just before we kind of go ahead with the anesthesia of Ralph. So this is an example of us having kind of a station ready. We have our tray, our kind of sheet, drugs, and the circuit checked, and we have everything available for induction. Also some warming aids. This is the pressure manometer I was talking about. So it's on kind of sideways, sorry about that. But this shows 5 to 20, the green area. So when we close our little APL valve and we provide a breath, this is the area where I want to keep the breath. And then pending any respiratory pathology, I may change the pressures that I use. But I honestly, we use them on our breathing circuits, and I really do recommend them on all breathing circuits. A glucometer in this case, because we have a controlled diabetic, but we will still monitor our blood glucose. This is a central line placement setup and an arterial line placement setup. Pre-oxygenation is another kind of sticky point at the beginning of an anesthetic. So why do we provide pre-oxygenation? Kind of, we say, so they breathe in extra oxygen. The real reason we're providing pre-oxygenation is so we fill a section of the lung volume, which is called the functional residual capacity. I'll show a picture of this in a moment, so no need to kind of rush with the words. But by replacing gas in the functional residual capacity with as close to 100% oxygen as you can get. Flow-by, if you're providing flow-by to a patient and they move their head, you were just providing maybe 35-40%, depending kind of how close and how accurate it was. As soon as they moved their head, they've gone back to room air. So it's very hard to get consistent pre-oxygenation with just a flow-by, and you see us kind of trying to chase them a little bit. The recommended and really kind of supported method of providing pre-oxygenation is with a tight-fitting mask for 3 to 5 minutes. And without that, we may not have achieved our desired impact with pre-oxygenation. These are the lung volumes I was talking about. So when we're providing our 10 to 20, 8 to 12 ml per kilo, this is the entire lung volume, our total lung capacity. This is our tidal volume. So you can see the little window that we're working in with our 10 to 15, 10 to 20 ml per kilo. Anything out of this, and we start kind of going into inspiratory reserve volumes, inspiratory capacity, and we can cause kind of volume trauma, bar trauma up above these kind of aspects. So that's why we're using these numbers to kind of direct our tidal volume and our intermittent positive pressure ventilation. And our functional residual capacity is what's down here. So when a patient breathes out, there's a volume of gas left in our lungs. They don't completely collapse. And oxygenation, ventilation is still occurring. And what we're doing, instead of this functional residual capacity having 20% room air, we're trying to increase it to 30%, 40%. If we have a prolonged induction and we have apnea, that will give us a window to reduce the chances of hypoxemia in these patients. So this is the kind of essential aspect behind pre-oxygenation. Then I think I'm prepared. Now I'm ready for my induction. I've, in Ralph's case, brought him to CT, pre-medded my patient. I'm providing pre-oxygenation. My station is set up. I've checked my equipment. My anaesthetist is present. And we run through a checklist together. We do use laryngoscopes in all of our patients. The maintenance is a huge aspect of what we do. It can be the 2, 3, 4, 5 hours after induction. This is just to show a general setup of how our kind of patients are set up in theatre, our setup, the monitoring that we're using, and an idea of how we would present an anaesthetic on a sheet. So how we monitor, we make notes of everything that we do, and we kind of like have lubrication of eyes. Essential, so we lubricate eyes every half hour, depending on the patient's needs. We don't have time to sadly go through the placement of a central line, but just an idea of, we do them, so nurses do them with the anaesthetist here. We train in them, we gain the necessary knowledge to carry them out, and then we're really supported by the anaesthetist here to do Schedule 3 procedures and to hone in on our nursing skills and to expand. This is one of our nurses just placing a central line with Robyn. And the arterial line is the same. Again, we could speak about it, but we only have a limited amount of time. But this is one of our nurses who actually was working in the anaesthesia department for about a year and a half and was kind of already succeeding in placing arterial lines, and that was his first arterial line. So it's a very unique moment. We kind of talk about them and we talk them down, but actually they're quite a high-skilled procedure to carry out. It just adds a lot of job satisfaction to what we do, and especially the support that we receive here in doing them. And as Sarah mentioned earlier, arterial lines are so unique because we can do oxygenation, so we can pull blood gases and we can check the oxygenation of the patients. So it's a very kind of unique aspect of arterial sampling. I don't know if you can see, but this happens every so often, but this is an arterial line that's been placed. Can't really maybe see, but it's pulsing. Because sometimes we place them in the dorsopedal artery and there is a vein running along there. And if it's a big dog, you can actually get quite a heavy flashback, and it can almost be confusing whether you're in the artery or in the vein. And equally, sometimes you place them and you don't get a lot of flashback when you're expecting it. So you have different ways to kind of confirm their placement, and the ultimate way is to run a blood gas using oxygenation and to confirm that it's arterial. And this is an image of it running. Arterial is real-time invasive blood pressure, changing all the time. And actually you can see here that our oscillometric is correlating very well with our invasive blood pressure. We do tend to run them both together out of interest, and then also because it's interesting, ultimately it's interesting to see how well the oscillometric is correlating with an invasive blood pressure. If you were to lose your invasive blood pressure for some reason, and we have Dopplers as well, just as a backup. And really the time when an oscillometric will just kind of not work very well, especially in a patient such as Ralph, is if we start bleeding or we start having arrhythmias, oscillometric will really struggle. So in this case, you revert to your invasive blood pressure 100%, and we have seen erroneous readings with oscillometric with arrhythmias and patients that have destabilized under anesthesia. This is the only video I have, sadly, of an arterial line running I've tried for the last 2 weeks, but I was just never in the right place at the right time. But you can see it running each time with a pulse. This is actually a cardio procedure, so there's like intense bit of setup. And then analgesia, I will pass you over to Robyn.
Cool. So one of the main things we have to consider in Ralph is making sure he's getting appropriate analgesia. And that is because he's obviously going to be having a surgical procedure. So there's different ways that we can provide analgesia. So we can do that systemically. So with things like opioids, we can do it sort of non-systemically. So we can use local blocks. And they're both techniques that in Ralph actually will be really, really beneficial. So why is analgesia important in this case? Well, uncontrolled pain is going to lead to a stress response. So surgery in itself, any painful procedures, they can cause a stress response in your patient. And a stress response is going to lead to stimulation of your adrenal glands in the end, which is going to release a lot of things like cortisol. It's going to release a lot of adrenaline, noradrenaline, from your sympathetic nervous system. And although these are beneficial to start with, they're really important for things like our fight and flight response. They can eventually lead to some detrimental effects. So things like thromboembolism, so they are very pro-coagulation, if I can get that right, and things like the pro-inflammatory. Obviously, to start with, these things are wonderful, but if they're left unchecked, they will cause problems for your patient. So one of the best things that you can do to try and reduce the risks of these things happening long term is ensure that your patient does have appropriate analgesia. So in Ralph, I'm going to be thinking about using systemic opioids. So a full mu agonist is going to be definitely in my pocket of drugs that I'm going to be giving him. Whether that's methadone or if I'm going to be using fentanyl, I've got them both available. It's in my practice, but it's very much going to be dependent on what you have in your practice and utilizing what you have got there. Both of them are very good drugs to be using in this case though. I'm also going to be thinking about local regional anesthesia. So in this case, he's having an XLAP. So I'm thinking about things like a tap block. So tap block is called a transverse abdominis plane block, and it's where we put some local anesthetic in between the muscle layers of the abdominal wall, where the nerves cut from your spinal cord run out, and your spinal nerves run out, and they run through here. And by adding local anesthetic into that area, we can provide quite a nice analgesia of the abdominal wall. And this has the benefit of obviously not only providing analgesia for your patient, but it is also going to provide a max sparing effect. And as much as I love inhalational anesthetics, they have made anesthesia very, very easy. They do have the detrimental effect of causing vasodilation, which in this patient is probably not the most ideal thing. He is going to be relying on vasoconstriction in some respect to maintain his blood pressure. And if we then vasodilate him, we're going to have a patient that's going to become massively hypotensive and then potentially quite difficult to manage. So if I can make sure that I am giving enough analgesia to ensure that I can have a max sparing effect, that is going to be beneficial for our patient in multiple different ways. This is one of our anaesthetists, and I think, is it UDD? Yep, performing a tap block. So it's something we do try and get our nurses very much involved with. And they're really good fun to do, and they can provide really nice analgesia. And unfortunately, this is not the best picture because of the way the light's shining on it, but
This is the peritoneum here, and then this is going to be all your abdominal organs. And then we have the needle coming in here, but it's just the lighting on a good day.
on a good day, we would definitely be able to see this.
And you're aiming for this space in here.
Yeah.
So you have muscles out here, and you're aiming for this kind of...
The white line is basically what we're aiming for. Fab. So that's the first thing we're going to be thinking about. And then I'm going to be thinking, okay, how am I going to manage my hypertension when it does occur? Because it probably is going to happen. So when I'm thinking about my blood pressure, I am thinking about my mean arterial pressure. So I ideally want it to be over 60, over 70 would be great, but I would be happy with anything over 60. And my mean arterial pressure is my cardiac output times my systemic vascular resistance. And my cardiac output is related to my heart rate and my stroke volume. So if I put all of these together, I will get a lovely little equation where I've got my mean arterial pressure is heart rate times stroke volume times my systemic vascular resistance. And then I can go even further and say my stroke volume is related to my preload, contractility, and my afterload. So in most cases, we tend to think of afterload and systemic vascular resistance as very, very similar. And for the ease of today, I'm going to just count them as one because afterload is a huge conversation in itself. So when I'm looking at this, I'm thinking, if I have a hypotensive patient, really there's only 4 things, within reason, that I'm going to be worrying about. And that's going to be my heart rate, my systemic vascular resistance, my contractility, and my preload. So the first question I'm going to ask myself is could there be a reduced circulating volume? So if Ralph's hypotensive, I'm going to be going, well, could he have a reduced circulating volume? The answer is yes. We've already bled, we're in surgery, and he could have bled more. We need to address this before we think about trying to use any pharmacological interventions. Because if you try and make a system work harder when it's not filled properly, you'll make it work hard, but you won't necessarily improve your output. Now, obviously, in Ralph's case, we do have mitral valve disease, so we do want to be maybe a little bit more cautious in what we're doing, but we can't forget about it. It is so important to make sure you do have appropriate circulating volume before you start pumping them full of loads and loads and loads of drugs. Obviously, you still might have to use the drugs while you are getting that volume back into him, but really we want to make sure that we don't forget about it. Then we've got, what is our heart rate doing? So in Ralph's case, it's probably going to be normal or high because we're suspecting he's going to be a little bit vasodilated, is probably our problem, or we've got a little bit of lack of volume. But in a lot of your other patients, actually sometimes the problem is they've not got an appropriate heart rate. So we give a lot of drugs in anaesthesia that sadly like to make our heart rate go very, very low. Opioids, alpha-2s, and that makes our life quite difficult. So we do want to try and make sure that our heart rate is appropriate for the situation that's currently going on. And here we tend to use glycopyrrolate to manage our heart rate. However, you can use atropine as well. They're both very appropriate. And then I've got to see what next. So afterload or systemic vascular resistance. So basically I'm going to be asking myself, have I got lots of vasodilation going on here? The answer is probably yes. If you have them on an inhalant, it loves to cause vasodilation. It is the sad fact of them. So we want to try and make sure that we reduce that as much as we can, obviously still keeping our patient anaesthetized, but we want to try and minimize the amount of vasodilation we have coming from the drugs we're giving. And we do that, as I said, by max sparing drugs. So we're using opioids, using local regional anesthesia. And if that doesn't work, then we can think about, is there anything I can do to cause vasoconstriction? So in Ralph's case, noradrenaline might be an appropriate drug to go to. In some of our less sick patients, we can lead to things like ephedrine and phenylephrine. And then the final bit is, could there be reduced contractility? And again, if you're using inhalants, yes, we can have reduced contractility. And when we're thinking about the drugs that we can use to manage that, dopamine and dobutamine are the 2 that are talked about quite a lot. I appreciate they're probably not drugs that you'll have in first opinion, but they're something to have a think of and know that there are drugs out there that you can use. I would love to go into talking about them in a huge amount, but we really don't have time and I could talk like hours on them, so yeah. And really, my lovely point there is sometimes just threatening with drugs can really bring your blood pressure up. I don't know why it is, but you can walk into a theatre and with your drugs all ready to go, and that's fixed the blood pressure. So yeah, so as much as I'd love to say that it's just us that do it, it's really not. The patients sometimes do fix themselves. So hemorrhage. So the biggest problem that in Ralph here is going to be hemorrhage. And I'm going to be worrying about how can I prepare for it if it does happen. So Ralph's already had a blood transfusion. And we know for a fact that it'll have been pretty recently. So in honesty, I'm not going to worry about blood cross-matching him just now. But I'm going to think, right, I'm going to try and still use a positive bag of blood that I've got there, and I'm going to have them available and ready to use. So if we have hemorrhage, crystalloids, you can use to replace volume lost. The amount of crystalloid you have to give to replace your volume is quite a lot. So let's say you lose 100 mils of blood, it's about 300 mils of crystalloid you have to replace it with. And that gets really challenging and has the negative effects of diluting what blood you have there. So you're going to decrease your total solids, and you're potentially going to decrease your PCB as well. So ideally, if you lose blood, it'd be nice to replace with blood. Whole blood would obviously be lovely to use, but we don't always have a stock of that available. So depending on where you are in your procedure, if you haven't given packed red cells before, packed red cells are probably going to be your first port of call. However, in Ralph here, he's already had packed red blood cells. And if I'm thinking he's bleeding quite a lot more, I'm also going to be worrying here about what are his total solids going to be doing. And I'm going to be thinking, well, actually, might it be worthwhile that we give him some fresh frozen plasma? Or if you don't have it, potentially just some frozen plasma. The disadvantage about this is you have to wait till it's defrosted. And defrosting, it can take quite a bit of time. And in that situation, everyone tends to start worrying about, I don't have it available, I'm not able to give it yet, what can I do? You're going to manage it with fluids, and you are going to manage it with You're going to manage it with drugs as well. While you wait for that to defrost, you can get it to defrost relatively quick. I think when you go onto Blood Bank's website, it's 20 minutes. And 20 minutes does feel like a lifetime when you are in this situation. But if you're prepared, ready to go, and you have other things there available, so even if that means that you are giving crystalloids while you wait, you are using pharmacology drugs to intervene at that point in time, that's fine. It's just knowing then that you are getting the plasma ready to then give them, whether that's in the recovery period or whether that is at the end of the procedure, you're getting it ready to go. Fab. So the recovery. Really importantly for recovery, here we obviously, we work in a team where we have a huge number of people that can be involved in a case. So communication is key. I'm going to call ahead and I'm going to tell ICU what I need and what Ralph needs. So if I'm worried about Ralph and I'm thinking I need to give him some plasma but I haven't got it ready or I haven't been able to give it yet, I'm going to ask them to get set up and ready to give it. I'm going to ask them to get some warming devices available, so whether that's a bear hug or blankets, depending on his temperature. I'm going to ask for syringe drivers, fluid pumps, because if everything's there and ready to go for when Ralph gets there, that's really important, because it means we're not then running around looking for things when Ralph's actually in quite a vulnerable position. A lot of people tend to think that anaesthetic's done, surgery's done, everything's fine and hunky-dory, great. But actually the recovery period is a hugely vulnerable time for these patients, and a lot can go wrong. And they do need to be monitored, and making sure you monitor his heart rate, make sure you're monitoring his blood pressure in that period can be really, really beneficial, because it'll let you know if things are going wrong quite quickly. So if you start to notice that all of a sudden in the recovery, his heart rate's going up, his blood pressure's going down, it could mean that either we potentially have another bleed going on, which is a possibility depending on how we've ligated those vessels, or the volume that we have given him is no longer maintaining his blood pressure, then we need to intervene at that point in time, and we don't want to miss that. And so it's really important to not take your eye off the ball and just because they're recovering. Obviously we want to make sure that we have analgesia, and then we obviously want to make sure that we write up our notes appropriately. It is really important, especially when you're working with a team that there's quite a few people involved in patient's care, that you have good notes. It's not only it's a legal requirement, but it really does make a big difference to your patient. If everyone knows what's going on and everyone is able to understand what's happened to Ralph through his procedure, it makes their continuing care much easier, even if you're not there in the building.